Okay, perfect. Thank you, everyone. Welcome to another episode or chapter of Oncology Beyond the Obvious, taking a closer look. Exactly 1.5 years back, Dr. Parikh sir and myself, we started this monthly webinar. It is held on every second Tuesday of the month at 7 p.m. sharp. What we do is we pick up one particular paper which is published in any good journal, and we dissect it out in 1.5 hours. The first part is the interview, where we invite one of the eminent oncologists of the country, where either Parikh sir or myself, we try our best to interview and take out the best information as regards to this paper. After that, we have a 45 to 50 minutes of panel discussion. And then last 10 minutes, an expert, again, an eminent personality in our field, finally concludes that in last 1.5 hours, whatever we discussed, is it making sense or is it practice changing in our country? This particular webinar, according to feedbacks what we get, has been taken very well in many institutes of India. In fact, 2 or 3 teaching institutes have made it mandatory for their students of DNB and DM to attend this particular webinar. We also had a physical webinar last year, and we are planning to do one this year also of OBTO, that is a relook. And now again, because of Parikh sir's efforts, we are going international with OBTO. And very soon we will make that announcement once we get the final confirmation of the same. So with that, I always enjoy this particular part that I am going to introduce Parikh sir. And as I said that, I don't think anybody is stupid enough who's attending this not to know Parikh sir. But Dr. Purvish Parikh sir, I would say, I can say for half an hour, I can say for 1 hour, and I cannot stop. We all know that apart from being an excellent clinician, an excellent oncologist, I think he's an amazing teacher and a human being. Ghanashyam also knows, and he will echo every word I speak for Parikh sir, that sir has shaped so many students of oncology's lives. He has guided them. Even in this Oncology Beyond the Obvious, I went to sir with an idea. And then sir always tries to make sure that, it shows that as if it is, I'm doing all the hard work, but he is the backbone of OBTO. And without his guidance, his support, his effort, OBTO would not have been where it is. In addition to that, I think one thing which I want to highlight about Parikh sir is that he's a teacher par excellence. I hardly have seen any oncologist who can teach the way Parikh sir. Of course, there are other types of teachers also. The reason
I can't hear anything.
The reason is, sir, इतना अच्छा आपके लिए बोल रहा हूँ, आप ही नहीं सुन रहे हो. Sir, you do it from your cell phone. Sir. So you do it from your cell phone.
Hello.
Sir, cell phone check karo.
Yes, you are.
Yes, you are audible, sir.
Okay, great.
Sir, I said a lot of things about you, and I'll repeat once I again this thing. But right now I was talking about how is he different as a teacher. Whenever he teaches students, he keeps students first. He will give them the priority. He will tell them to move forward. If any student writes a particular paper, he will make sure that that student's name is the first author, or whatever authorship the student requires the credit, he gives that, and he keeps giving guidance throughout the life. And sort of, I am one of them. So I always enjoy whenever he's around. So with that introduction, I will give the stage to Parikh sir, and sir will take this forward, this particular chapter of OBTO. Thank you so much, Parikh sir. Sir?
Amish has stopped speaking. It is my turn to speak, I think. but I am not able to hear anything. So my apologies. I don't know what's going on at my side. Can you guys, Himanshi, can you hear me?
Yes, sir.
Yes, sir.
Okay, that's a good idea. I should do from cell phone. So can you go back one slide? Okay, there's no previous slide. So first, let me start by introducing Dr. Geeta. As you all know that she is a Delhi girl, right? She has done her undergraduate and postgraduate studies from Delhi for Lady Harding and Mamsi. And then she has also done FRCS from Glasgow. We all know that she is head of oncology and with special interest in breast at Max Hospital. But as Amish said, she is also an avid singer, and at least 3 singing groups benefit from her voice and her participation. We are also very fortunate that she is here, because if this program was next month, then she would have been in the midst of wildlife in Masai Mara. Am I right, Geeta?
That's right. Yeah.
Really very fortunate. And she is also an avid reader, and all the philosophy that she gets from a book also, influences how she deals with patients. So she is always perceived as a very kind, uh, sincere, and genuine doctor by her patients, and therefore they are very fortunate to get treated from her. Uh, can we have the slide, please? As is normal, I will first start by showing you a very brief summary of the uh, publication that we are going to discuss, and then we'll go with the questions for Dr. Geeta. So this is the paper published in May 2023. You can see that the first author is from Dana-Farber Cancer Institute, Harvard Medical College in Boston. And our very favorite Dr. Martin Picard is there, because this is part of the Breast International Group, the positive trial collaborator. Next slide. The inclusion criteria says that all patients who are less than 42 years of age, stage 1, 2, and 3, had received adjuvant endocrine therapy for between 18 to 30 months, and of course, desired pregnancy. The primary endpoint was the number of breast cancer events, and the analysis was planned after 1600 patient years of follow-up. And a pre-specified safety threshold said if there are more than 46 breast cancer events, then this trial is not safe and it should be stopped. Of the 516 patients who were included for the primary efficacy analysis, you can see that the median age was 37 years. Next slide. The median time from breast cancer diagnosis to enrollment was 29 months, 93.4% at stage 1 or 2 disease, 368 out of 497, that is almost 3/4, had at least one pregnancy, and 63.8% had at least one live birth. So a total of 365 babies were born in total. The follow-up was for 1,638 patient years, so that milestone was met. And 44 patients had a breast cancer event, so safety cutoff was also met. The 3-year breast cancer event was 8.9% in the study group and 9.2% in the control cohort. Next slide. This is the breast cancer event-free survival, and you can see that the red line and that is the treatment interruption, and the blue line, which is the control cohort, are almost identical, with significant number of patients at risk. Next slide. Similar results are also seen for distant recurrence. Again, the red line is the treatment group, and the control cohort is in the blue line. 4.5 versus 5.8. And again, there are sufficient patients that follow up even at the end of 48 months. Next slide. Next slide, please. Now, this is the forest plot. The vertical line is the point at which the results between the two arms were supposed to be identical. And you can see that everything is crossing that line of unity except one subgroup. And that is the patient whose treatment was included aromatase inhibitors as well as ovarian function suppression. Next slide. So outcome that occurred at least once was 368 women with 507 pregnancies. As I mentioned again 63.8% had one live birth. And very interestingly, there were 110 women with more than one pregnancy. And so much so that one lady had as many as 5 pregnancies. Very interesting. Next slide. The authors have also clearly mentioned some limitation and challenge. The limitation was the median follow-up was only 3.4 years, and protocol-specific 10-year follow-up will be critical for final evaluation. There was some concern about women not resuming endocrine therapy even after becoming pregnant and the child is born, and this was 15.4%. But if you look at similar trials, that is soft and text trial, there were more women who discontinued endocrine therapy or did not restart, and that was nearly 20%. Next slide. The other challenges they mentioned was effect of healthy amount of bias, whether the matching methods were sufficient or not, and whether the trial population is a robust representative of the broad population of premenopausal women. Next slide. So the conclusion of the authors was positive trials showed no clear worsening of breast cancer outcome in the short term after temporary interruption of endocrine therapy to allow for pregnancy in select women with a history of hormone receptor positive breast cancer, and long-term follow-up is necessary for confirming the safety. Next slide. So with that, the slides are over, and now I will go to ask my questions to Dr. Geeta. I'm going to divide them into 3 parts. The first part are questions in general about the practice that happens in India. The second would be specific to the NEJM article. And finally, we are going to grill Geeta with rapid fire yes, no sort of questions. So first question, Geeta, is are patients with breast cancer and pregnancy common in your practice?
Thank you, Dr. Parikh and Dr. Amish, to have me on this show. And I think it's a great experience, a very different kind of experience. And to answer your question, fortunately, we're not seeing so many of these patients, but this question is coming up more often than not. But yes, we are seeing these patients more and more frequently now, and possibly because our mindset is also changing as we go.
All right. And is it more common during pregnancy, breast cancer treatment, or after breast cancer diagnosis is over, treatment is over?
Sorry?
The incidence of pregnancy, are you seeing simultaneously with the diagnosis of breast cancer or afterwards?
So pregnancy-induced breast cancer, associated breast cancer, fortunately, the incidence is still not high.
All right.
But when we see them, we are picking them up as locally advanced breast cancers. And of course, in the year that, this is a long period. It is not just about during pregnancy, it is up to a year after pregnancy also. But we are picking them more often while they are pregnant than rather in the postpartum period.
Right. So in your practice, of course, being in the metro city of Delhi and, looking after the elite patients of society, it may not reflect everything that is happening in the rural India. But can I ask you, do your women say that while they are in your care for the treatment of breast cancer, express their concern that they would like to have biological children in the future?
So I think it is both ways. There are 2 ways of looking at it. One is how the clinician feels about it and how the patient feels about it. It is not often that you would, so the clinician has to volunteer this information, has to put this question in the mind of the patient. Only then will they be comfortable talking to you about it. And of course, then there are patients, the empowered patients may ask you this question, that they do want to have a child. But somewhere the truth lies somewhere in between, because, the overarching, factor of the diagnosis of breast cancer can actually, put things out of perspective in a way. So I think it is both ways. But now I think this question is being asked more often than not.
Today, women are focused on their profession as well, and they sometimes postpone having a family or having children. When a young person with breast cancer comes to you, this struggle is always in the mind of what is happening. And then this has been reported to have some psychosocial issues if they become pregnant later. Has that been your experience in your practice?
Yes. So, unfortunately, in our country, still the decision regarding a patient wanting to have her own children is not decided by her alone. There are a lot of people making this decision.
Right.
And it could be just an offhand remark by somebody, oh, you've got breast cancer. Why are you even thinking about things that don't matter? Who knows, you're going to live to be, a mother. Why don't you just think about getting out of this sticky situation? They barely ever talk about it. So we have these social issues which sometimes take away the real essence of an individual and don't let them make these decisions. But if left to her own devices, the empowered woman would definitely be more participatory and would want to make that decision for herself. And I would think that if you were to give her the right picture, she would choose to be given that option of, having a biological child subsequently.
Right. And last time you had also mentioned that some of the social circumstances in our country are unique. So lady might already have 2 daughters, but still want an additional child.
Yes. So only recently I had a patient like that who has 2 children, and she's only 26. So one of her questions was, so am I not going to be able to have more kids? I said, but you've got 2. She said, but both of them are daughters. I want a son. So, these are the kind of societal pressures that women live in. And but then she came back for a second consult. Now she's kind of eased off because her husband is in the picture and he says, it's okay. I'm happy to have those 2 kids. Don't feel the pressure.
Awesome. So, right, like you rightly pointed out, active counseling is really crucial in these patients, and that has also been published in literature by many people. Now, there are at least 2 very good publications about breast cancer and pregnancy being detected at the same time. And Jyoti, we are very fortunate that Jyoti is here. He has published data on 104 patients from Tata Hospital, and majority of the patients were born alive. So also Sunita Sharma from Kolkata has published on 623 babies. And she found that there was no difference in congenital malformation in the patients who got letrozole versus those who did not get. So it's really nice that we are having data about simultaneous breast cancer and pregnancy. But now we are talking about actively stopping endocrine therapy to allow breast cancer. So I will come to the NEJM article per se. So my first question to you is, what are your thoughts on the inclusion criteria? Why was the inclusion up to the age of 42 years? Most publications is either 40 years or 45 years. So what is so unique about 42 in this article?
So I was giving it a thought, what I thought was, they have taken a cutoff of say 45. You're not possibly going to be, be able to conceive after 45. So they possibly taken the upper limit as 45 in the sense that, besides because once you're included, you're still given about 3 years to, 2 years to conceive. So I think that is the reason possibly they took 42 as the, latest point by which they can conceive, because I'm sure after that, your ovarian reserve is not going to support such a possibility.
So it's probably related to the normal, what happens in menopause among the women that are likely to be included in the study.
Right.
The second question or concern I had was, why was patients with stage 3 included? In any case, it formed less than 7% of people, right? So
Yes.
by including stage 3, did they actually complicate the interpretation and analysis of this data?
So I think, we are living in times when, there is a lot of blurring between the stages, primarily because of the kind of advancements we've had in treatment. So I don't think we should be denying the patient a chance just because she's stage 3, because
Yes.
even in stage 3, one has a reasonable chance of long-term survival with the right kind of treatment and the optimal treatment, as we may say. So I don't think one should be denying the patient a chance just because she's stage 3. I think we have to live on hope. And if you don't give a patient of stage 3 the hope of, there is something to look forward to. You have to tell her, for all you know, you may be having babies, after 2 years, after, say, interruption of endocrine treatment. So that's a good thought to live with. Why not?
So I think that positive philosophy is exceedingly important. And thank you for sharing that. Now, the next concern I had about the inclusion criteria was that they allowed interruption of hormone therapy after only 18 months. And I thought normally we would have said at least 2 years, 24 months is required. So what is your thoughts on this?
So I would agree with you, because 18 months seems to be too short a time. As it is, hormonal treatment takes time to kick in. And I would, this is our fundamental thinking that it should at least be 2 years. But yes, they have decided to interrupt. 18 months is like kind of, I would also think it is kind of cutting it a little close.
Right. Now, there is increasing interest and knowledge about BRCA1 and 2 mutations in patients with breast cancer. And, Matteo has published article on 1,252 patients with germline BRCA mutation, and 195 had at least one pregnancy after breast cancer. So do you think that presence or absence of germline BRCA1 or 2 mutations would influence the decision that you make about allowing such patients to interrupt endocrine therapy for pregnancy?
I think again, so now the choices have widened. I think we should not be denying patients with BRCA mutations also the opportunity to have their own children. But I would think that, if there is an embryo cryopreservation, because you want to be sure that your child is not carrying that mutation, it is possible now. With PGD, with prenatal genetic diagnosis, you can actually do that. And you can possibly have 9 or 10 embryos stored away, and then you can look at it at the time of implantation. Before implantation, you can look at it and see if it is carrying the mutation or not, and just choose to implant the one which does not have the mutation. Isn't that wonderful? That a patient who is BRCA mutation is guaranteed that her child is not going to carry the mutation because they have pre-selected it.
Right. And we have Madhuri, an IPF specialist, in the panel, so I'm sure that she will be able to answer many such questions. I remember an incident where Madhuri and I were discussing about a patient, and she wanted to preserve the oocytes or ovarian tissue by a very brief stimulation, and it would have involved 2 weeks. And at that time, I was very skeptical about that. But today I changed my mind, and I'm very happy that she is able to offer such services for our patients. Now I'll move on to the next question. In the NEI-JM study, 110 out of 497 women had more than one pregnancy. Isn't that very impressive? 1 in 5 went on to have more than one kid. Today, our society wants a nuclear family, where some of the mothers went on to have 5 children. So what are your thoughts on this?
I think it should not apply to our population. We are happier with 1 or 2. But I still believe that in the West, so many countries reporting a negative growth rate. So you look at the Scandinavian countries. So there are a lot of developed countries showing a slower growth rate. I'm sure they would be wanting more kids. So they're most welcome to have 5. But I would think that in our country, even if we were to have 1 biological child, at least you're fulfilling that need to be a mother. And I think, or maybe 2, but and I'm a little surprised at how in that period of 2 years, they managed to have 5 kids. So is it triplets or twins? What was it?
Absolutely right. Because when there is assisted, fertilization, then it's likely that it could be twins or triplets. Mary Abel has reported on factors that determine the success of pregnancy after patients have received chemotherapy for breast cancer. And this was a prospective cohort between 2010 and 2019 of 181 participants, 46, 25% attempted to conceive following chemotherapy. And 35, 76% had return of ovarian function. And of these 34 patients, first attempt to conceive by intercourse was successful in 64% of instances. And of course, in case it is not successful by normal means, there is always the possibility of using fertility preservation and also the assisted reproduction. So if a new patient of breast cancer comes, do you discuss options of fertility preservation with them?
So now, if you were to ask me this question about 7 or 8 years ago, maybe kind of reluctant, because we did not have those many fertility specialists, and it was not ingrained in our mind also. But today, I would possibly suggest it to every single patient, even those patients who already have one child or maybe 2 children, because you are bound to, because you don't know what is there in their mind. They may be wanting another kid. So it is a uniform discussion in all women under the age of 40, if they are desirous of having kids. So that discussion happens in every single patient.
So another publication by Ornat was about the role of ART, and total of 25 out of 198 patients underwent ART. And 90% of these patients had actually received adjuvant chemotherapy. And more than 50% were endocrine sensitive. And the pregnancy, full-term pregnancy was achieved in 75% of them. So ART is also seeming to be very successful, and the outcome, the overall survival, disease-free survival, seems to be identical to patients who did not have breast cancer. So that is really a nice feature. Now I'm going to come to the last part of the NEJM paper, and that is what were the limitations. The author, I think, have been very generous in trying to avoid criticism by showing that there are several limitations. But actually, the most important limitation I feel is only that the follow-up has been only 3.4 years. So Geeta, I want you to hold the crystal ball in your hand, gaze at it, and tell us, what do you think? Will the safety be continued? Will we still be impressed with the results as we have a 10-year follow-up or not?
So for the sake of my patients, I would think that it should remain and it should sustain. And we should come back with similar results or possibly even better results at 10 years. I do understand that 3.4 years is a short follow-up, but it is a very optimistic view. And I think we should maintain that optimistic view. And if you ask me, if I were to have my own crystal ball, I would think that it should sustain at 10 years also.
Awesome, awesome. Again, your positive attitude is coming out. Now, let's look at the other side. There are a significant number of women who are young, who may or may not have children, but are very fearful of becoming pregnant after the breast cancer treatment is over, even after everything is over. And there are several reasons that they cite for them. One is the fear of the disease coming back. The second is the fear that the child might have to grow without one of the parents. The third is that they don't have libido, and therefore there is no real interest in sexual activities or getting pregnant. Do you find this also as a concern in your patients? What are your thoughts on this?
So what you bring up is a very, very important aspect of the treatment and post-treatment time, which is rarely discussed. We do not talk about sexuality because the focus is largely on the sexual act, which actually needs to be modified, because while we're talking about psychological counseling, we should be also talking about sexual counseling, because it is not just about the act, it is about how you express yourself. And I think, both partners need to be made to sit down and told about how you have to modify the way you express yourself sexually. And that does not necessarily mean culmination in a sexual act. It is a tough ask. We don't discuss it, but the fact is, it is important. We have seen relationships crumbling just because, the woman has not been able to, like you said, she suffers from lack of libido, doesn't have the desire to perform, and the expectation at the other end remains what it was pre-treatment. So I think this modification has to happen. We have to become more and more empathetic. Both the partner has to be made to sit down and told how things are different now, but it does not change anything in the level of your affection or, I know it is easier said than done because there are issues and we face it all the time. And I am trying to make a concerted effort to create this group of people who can do this kind of counseling, because it is a very important aspect of their lives which need to be addressed.
All right. So we are already at 7:30. So I will move on to the rapid fire question. And I request you to just be very brief, answer yes or no. Okay, so that we get a clear message to the audience. First question is, would you call this paper as landmark and practice change?
Possibly practice changing, yes. I have something to fall back on. So when I'm talking to a patient, I have more conviction now because there is proof.
Right.
Even if it is 3.4 years. And as we are talking, the time only is increasing. And I'm sure we'll have a lot.
Right. The statistical method mentions that 2% annual risk of breast cancer recurrence is acceptable, while 4% is too high. Do you agree with this?
No.
Okay. Do your patients' opinion about regaining sexual function differ among those treated with breast conservative surgery versus modified radical method?
I don't have any evidence to this, but possibly breast conservation fares better.
Okay. Do you agree with the statement that there are no increase in birth defects in children if mothers were given chemotherapy early?
Yes.
With respect to monitoring pregnant women for breast cancer recurrence in general, the recommendations by ASCO regarding monitoring in non-pregnant women should also be followed in pregnancy.
Same, yes.
Yeah. Do you agree with the statement that pregnancy does not increase the recurrence of breast cancer?
True.
Okay. Last question in the rapid fire. From tomorrow onwards, will you use this data to allow your breast cancer patients to interrupt endocrine therapy in case they want to get pregnant?
I will certainly offer it with caution. But yes, if there are patients who are willing to take it.
Excellent. Thank you very much, Dr. Geeta. I think this has been a very stimulating discussion. And please stay back as part of the panel discussion. I now hand over to Dr. Ghanashyam Biswas, my dear friend, who is senior medical oncologist from Bhubaneswar. Ghanashyam, over to you, and you can start with your discussion with your panelists whose name are on the slide here. Thank you.
Sir, before Ghanashyam takes over, I just wanted to add one line about Ghanashyam. This particular topic, I think it is apt for Ghanashyam. We all have seen Ghanashyam is so emotional and empathetic towards his patient. I think कोई patient ने आज से 5 साल पहले आके बोला होगा कि Dr. Ghanashyam, I want to become a mother. He would, I'm sure the tears will come in his eyes. And now we have the evidence after evidence coming forward for that. I think Ghanashyam is an apt person to discuss this. Sorry, Ghanashyam, I couldn't stop saying this. Over to you, please. Thank you so much.
Thank you, Amish. And thank you, Purvish. And that was a great insight by Dr. Geeta. I recently met her in the MetroCon. I heard her talk also in Delhi. So the NEJM article, May 2023, even a part of this paper was presented last year in the San Antonio. So interrupting endocrine therapy to attempt pregnancy after breast cancer. And in the San Antonio, the title was Pregnancy Outcome and Safety of Interrupting Therapy for Women with Endocrine Responsive Breast Cancer. So that's actually a positive, that is what the positive trial is all about. So these are 4 ladies and 4 gentlemen. And so before I start, So there is also an evidence for gentle reminder this can happen to us also, though it is in a webinar. So Amish might push off stage me or the panelist. So there is an evidence for that. Just
Actually, Ghanashyam, you are only showing the first top half of this slide. At the bottom half, the last paragraph is also very interesting, but we'll take that offline.
right, sir. So at times, so only presence of mind will do. Like my daughter is a good artist, so she says कि पापा तुमको drawing नहीं आता है. But if you put your mind into, so this boy who is not a good artist, so what he draw, so he just made a wall and that he represented that it's an elephant. So at times a presence of mind will do, and so probably in the author's mind also, so not only emotions but a presence of mind, some patient might have spoken to them, and that's how they designed this trial. So let's come to first Dr. Shirish. So what do you understand by pregnancy-associated breast cancer? Dr. Shirish.
So pregnancy-associated breast cancer, what I understand would be, pregnancy developing in a patient with breast cancer, becoming pregnant, or pregnancy developing immediately, say after the chemotherapy. So within what I would think would be within 2 years of, I'm not very sure of the definition, but I think it would be associated with pregnancy.
Right. So I was also not sure, but I went through Jyoti's paper. So pregnancy-associated breast cancer is a rare entity and defined as breast cancer diagnosed during pregnancy or 1 year postpartum. And that makes us this paper more relevant. And as we go on, we'll find that there is a sparse data, especially from low and middle income group. Now coming to effect of pregnancy on cancer. So we can just touch upon, and we'll always remember the first slide. So moderator getting pushed off. So we'll start with Chetan. So common cancer missed or delayed any hormonal effects, or so would see a different biology of disease.
Quite likely Biswas, because a lot of times the breast lumps are missed because of breast engorgement, and a lot of lumps which may be cancerous are often neglected, saying that this could be just a galactosele or something. So that happens quite often. Biologically, I don't know how different they are. I honestly have not read anything about the different biology. So I don't know about that part. But definitely there are some. Pregnancy obviously becomes a priority. So all other symptoms are.
Chetan, what are the other cancers? So in your last 2 decades of practice, besides breast cancer, so pregnancy and any other cancers you have come across?
Yes, I have seen solid tumors of other organs as well, but they have largely been neglected because pregnancy was a priority. So the lady was told to first finish off the pregnancy, and then after delivery, they were going to evaluate the lady.
So coming to Dr. Neha. So Neha, how do you approach? So now we talk about breast cancer, since you are a breast surgeon, and recently you gave a talk also in our platform also. So how you address as a team, and because your team includes Vivek as a medical oncologist, and how do you counsel?
So, sir, pregnancy-associated breast cancer is something which ideally should always be discussed MDT, and we should have an obstetrician as a part of MDT along with medical radiation oncologist, radiologist, and a surgeon. Issues with pregnancy-associated breast cancer starts right from diagnosis. At the time of diagnosis, because we cannot do a lot of investigations. Mammography can be offered, but with a shield, abdominal shield. MRI with contrast cannot be offered. So the question of multicentricity is an issue. The second thing is, what semester is the pregnancy breast cancer diagnosed in? Because if it's in second trimester or third trimester, then probably things are not so difficult. First trimester, it's more difficult. There are more other issues. Chemotherapy, by far and large, anthracycline-based chemo can be given, especially if you are giving in second trimester. Surgery, again, I would always like to offer surgery after the delivery and probably cover the duration of the pregnancy with chemotherapy. That would be one of the options. So we need to really sit down with the patient, discuss with her that what is the pros and cons of pregnancy, continuing pregnancy versus terminating. What is it that she desires? How precious is the pregnancy? And also, as I said, which trimester is in it? Is it very early on or late? Also, the possible effects on the fetus, if slightest, because there's always this slight chance. And also because there are certain treatment which will not be offering her, so her prognosis, how it is going to be different. So these are things you need to discuss.
Absolutely. Absolutely. So this is how the coexistence almost in 1 in every 1,000 patient pregnant women, especially difficult because of the changes in the body, which includes bloating, headaches, nausea, vomiting, breast changes, and probably this overlaps with some of the cancer symptoms. So unless and until the patient comes to her gynecologist or a family physician and that doctor examines her and thinks of a cancer, then probably so you are going to miss. So these are the common cancers that has been associated with pregnancy. So not only, so any cancers can happen, but the commonest are actually cervical cancers, thyroid cancers, Hodgkin's, non-Hodgkin's, melanoma, and gestational diseases. So coming to a cancer and pregnancy registry. So cancer, pregnancy during cancers are not only treating two patients, and not only treating one patient, so we are basically treating two individuals. And cancer during pregnancy is still a difficult journey to navigate. So more and more papers are there, and this registry just started in 1997. And then, so now, so we'll come to Dr. Jyoti, so who has been a part of the Indian registry. So Jyoti, all over to you. So you can just highlights about this paper so that many of us who are not aware of this paper. So Jyoti.
Thank you, Biswas. And this is a topic which is really, really close to my heart. And I would say that, challenges are there for women who are empowered and they want to, live their life as normal as possible. And vis-a-vis also, these are the similar challenges to a woman who is not really empowered, who is not taking her own decisions, but pregnancy and conception become, a biological, need for her or the family. So, these days when the women are postponing the childbirth, the incidence of pregnancy-associated breast cancer is increasing. And as you rightly said that there is two components. So it is either during pregnancy or in postpartum. There are several definitions which are there. And previously, the one which we have used in this paper was the most acceptable definition, that during pregnancy or within 1 year. But now again, the people who are very active in the field of pregnancy with cancer, they're strongly feeling that, these two entities should also be separately dealt with, because there are different principles. So antepartum, so during pregnancy, and postpartum, now they are addressed differently. The major challenges are when the cancer is during pregnancy, because that time the physiology is changed and we have to make various considerations to safeguard two lives of the mother's oncologic outcomes, similar time the pregnancy outcomes and the fetus. So which is trimester dependent, essentially multidisciplinary care which is required. And with the advancements and with the close monitoring, we are really able to safeguard the lives of both, and without compromising the oncologic outcomes, which is very gratifying. And this has been similar kind of trend in Europe and in our part and North America and several others. So the key is that we should be avoiding the delay the diagnosis, which is kind of very rampant. In our own series, we found that almost 70% has delayed diagnosis, so more than 3 months, and majority of them 6 months. Because again, the misconception from the primary caregivers, obstetricians, etc., that whatever the changes are, they are due to pregnancy-related hormone. So that part must be considered, and awareness and education is very much required. Then first, all the 3 trimesters are safe for as far as breast surgery is concerned. We need to be cognizant about whether we are doing MRM or breast conservation, because conservation demands radiation, which is a thing which we want to do only after delivery. So chemotherapy, second trimester onwards, anthracycline and taxane both have shown safety. Chemotherapy must be stopped around 3 to 4 weeks before the delivery, so that we can avoid puerperal infections, sepsis, bleeding, etc., those kind of risks. So there has to be an obstetrician, fetal medicine expert, and breast surgeon, breast oncologist, and other support system every time in the decision making. So that is important. With that, anti-HER2 therapy, so targeted therapy, hormone therapy, radiation, they should be kept for after delivery. So these are the broad principle. Otherwise, we can actually manage the woman in the similar manner with a similar kind of standard treatment as a non-pregnant woman, and can safeguard the oncologic outcomes as well as can take
Right.
the full-term delivery.
Thank you, Jyoti. So 8 years almost of a registry. So kudos to Dr. Jyoti and team from our alma mater. So there were 104 patients. So the median age was 31 years and 40% are triple negative. Though it is not a big cohort, but if you see the conclusion of this paper, so majority had a delayed diagnosis, as Jyoti rightly said, and aggressive features. So triple negative, higher grade expected because the median age is 31 years. But treatment was feasible in majority and stage matched out were comparable to the non-pregnancy associated breast cancers. So now coming to effects of cancer on pregnancy. So coming to TP. So the disease, investigation, treatment, the counseling. So we have already discussed a bit while discussing this. So you can just have your words on this.
Regarding the investigation, I think so it is very clearly that we have to avoid any X-rays or the CT scans. That's very clearly pointed out by everyone here. Treatment part, I think, is well covered. I would not go into that. That surgery appears safe. Chemotherapy in the second trimester or beyond. Hormone therapy to be avoided because we do not know what the fetus sex is. And we also are going to avoid radiotherapy. I think that's what it is all about for me when I see a patient with breast cancer associated with pregnancy.
Absolutely right. So now coming to Dr. Madhuri. So as an infertility specialist, so a lot of medical oncologists and hematologists treating Hodgkin's, which comes in a young boy or a girl, and we are worried about their subsequent fertility issues. So we send to our gynecological friend and then try to preserve oocytes and the sperm. So do you get a frequent consultation or a calls for a similar in a breast cancer, just to have an oocyte with somebody getting a breast cancer diagnosis at 30 and she's not pregnant yet or she has not had a baby? So what is your experience, Dr. Madhuri?
Yeah, so we do have patients who come for fertility preservation with breast cancer, but many a time the patients come directly to us. But what I have seen is that the oncosurgeon as well as the medical oncologists are really not ready to, make the patient wait even for 15 days, for preserving the oocytes. So even if we tell that we'll do it in 15 days, because now we have random start protocols, wherein we need not wait for the second day of the periods to start a protocol, ovulation induction, and then do either the oocyte retrieval. And then if she has a partner, we can preserve the embryos. But to maintain the autonomy of the patient, it's always best to preserve the oocytes, because if she has a divorce with this husband, she can always use the oocytes when she gets married again, because we really do not know about the social adjustment which happens after you get breast cancer. We also have an option of ovarian tissue cryopreservation, which is very, very important. And that does not really require to wait. And if the patient has even one day, we can just do a laparoscopy and do ovarian tissue cryopreservation, which we are doing using vitrification as well as slow freezing. But most of us in India who are doing, we are having about 4 or 5 centers in India who are doing oocyte cryopreservation, and what we are using is vitrification. When they were talking about breast cancer, I just wanted to tell that except for radiation, and today I think ultrasound is one of the methods which is used as a diagnostic modality, and you can always do an ultrasound guided biopsy. And I think MRI also is safe. It's only radiation that should be prevented during cancer. And when we talk about ovarian tissue cryopreservation, only one thing we need to keep in mind is those patients who are BRCA positive. we have to be careful because we know that these patients also have a higher incidence of ovarian cancer. And therefore, when we are re-implanting this tissue, it's best to test whether there are any metastatic implants of cancer in the ovarian tissue.
Thank you, Dr. Madhuri. So I'll come to Amish if he's there. So Dr. Madhuri rightly said, so many of us today, after the diagnosis, biopsy is done, ISC is done, and the PET scan is done, we try to jump into for treatment without thinking of the oocyte or the sperm preservation. So Amish, so what is your opinion?
No, so it again, stage 4 cancer also nowadays, hormone receptor positive. I have at least one patient last year who said, "Ki sir, aap keh rahe ho ki I can live for long. Can I plan my family before I die?" And me and my husbands are clear. So I actually counsel everyone for fertility preservation before we start chemotherapy, and we don't jump for chemotherapy. Last year, we had 3 breast cancer patients who took a break of 2 weeks before starting chemotherapy. They went to their fertility expert and did their treatment, and then we started the treatment. Lymphoma also, this uptake is almost 60 to 70% of the females. Ghanashyam.
Right. So coming back to TP again. So TP, this is a recent paper. So I just got this slide. So you can see the yellow or some orange one, no? Not supported due to the limited evidence except for rituximab and imatinib. So now we know that 20% patients will be HER2 positive, even younger patients may be more than that. So do you think that this targeted like trastuzumab also needs a similar sort of trial?
Evidence is always good, Ghanashyam bhai, but most important, I would just lead into it that there is not enough scientific published data. That's why they're told it is not reported due to limited evidence. But I would not hesitate to give a patient and offer trastuzumab, although strictly if someone is a purist, you have to take a consent for that. I feel that has to be done. But I would otherwise be comfortable using a trastuzumab if I leave it to me, because I do not see any teratogenic effect per se. If anyone is aware of, I am open to be corrected here. So that only tells me that the literature is evidence is limited, and that is expected because the publications are not there for a trastuzumab based therapy.
So if you look at the literature, because I searched just so in chemotherapy, so they said anthracyclines, not even taxanes, so no hormonal therapy. No,
taxanes is safe, and I think all the guidelines have updated it. And even Jyoti told that anthracycline, taxanes, both will be considered safe and equally efficacious and should be advised as per the risk criteria.
So Jyoti,
I agree with this that there is more data for anthracycline because it is more than many more years of experience, but the data with taxanes is also now decent enough, and they both are considered safe in pregnancy, second trimester onwards. About the targeted therapy, so they are not per se teratogenic, but there are chances of oligohydramnios with trastuzumab, and contrary to chemotherapy, which is more detrimental if it is used in first trimester, because targeted therapy is not teratogenic, but it is having effects on renal tubular cells and other parts, and it leads to oligohydramnios. So a second trimester onwards, it is more risky. That is what. And HERA trial, the patients accidentally got exposed to trastuzumab and they got pregnant. And there are on those patients, this data is there that they developed oligohydramnios and those kind of things, but per se not teratogenic. So if possible, they should be kept after delivery. That's what is suggested.
Right. So coming to Dr. Geeta. So now, Dr. Geeta, so since you spoke so nicely for the initial part, so now, so pregnancy associated breast cancer. So we do understand that we need to work as a team. So what's your opinion on takes in just a short answer?
So like Neha also mentioned at the beginning, all of this requires a team effort. And I think, you need to include all the stakeholders right at the beginning rather than trying to, catch at strings here and there. So I think, like Neha said, an obstetrician in the picture early on, along with the medical oncologist and radiation oncologist. Obviously the surgeon is the person I assume to whom the patient has gone to. So I think, all these people have to work in tandem. And everybody has to be aware of the needs of the patient and then address it accordingly. And I think together, I think we can change the picture, because it is a huge emotional need for a patient, and I think we need to address it. And I'm really happy that the thought is going in that direction, and I'm sure we can get great results.
Right, so absolutely. So this is a recent paper which shows these algorithms, so how the obstetrician, the neonatal care, and the oncologist are in a tandem. So we talked about that first trimester. We are not going to address anything in the medical treatment. So second, third is rather safe. So, Dr. Madhuri, so do you have any experience in last so many years of practice? So patient has received chemotherapy or some form of medical treatment in a breast cancer, and you are a part of that childbirth. So birth defects or any abnormality in the delivery. So any thought on that?
No, usually I don't think chemotherapy is associated with any congenital defects. But basically, we should consider that post-chemotherapy, getting oocytes and the chance of pregnancy is very, very less if you're giving chemotherapy, because we know all the chemotherapeutic agents are toxic to the gonads. And therefore, the chance of pregnancy is very rare, unless the patient is not given chemo and she's only on hormonal therapy. And at that point also, we need to look at the age at which it is diagnosed, because I think at least a minimum period of 2 years, we have to give her the hormonal therapy. And if she's already 37, 38, then it's best to do fertility preservation before she goes on hormonal therapy. And later on, she can go for embryo transfer at any point of time. Because once she has oocytes or embryos which are cryopreserved, then to go for a pregnancy at any point of time, even when she's 45 or 50, it doesn't really make a difference. But if she comes for fertility at that point of time and she doesn't have anything cryopreserved, then I think getting pregnant also would be very, very difficult. But just because she's taken chemotherapy, the child really does not have any problem.
Right. So etiologies of fetal growth restrictions in women with cancers, fetal cause, especially congenital anomalies, if first trimester exposure, there can be certain placental cause and mainly maternal cause. So it can be cancer treatment itself or the investigation, so what we discussed.
It is only if you give radiation therapy, then the uterus and the cervix is affected. And then only you're going to have all these what you've described. Just with chemotherapy, you do not have any of these. You don't have a preterm birth, you don't have PIH, you don't have anything, because the chemotherapy does not affect the uterus or the endometrium. So it really does not make a difference.
So Dr. Shiri, so the whole buzz is about immunotherapy for last more than a decade. So what is your take on immunotherapy as a treatment? So we talk about chemotherapy, hormone target. So what about immunotherapy during pregnancy?
Not much data. I think Jyoti would be the ideal person to answer that. Not much data. I think with immunotherapy, where do you use a triple negative? That's the only indication, I think.
Yes, so at present, we really do not have data to support its use. So at present, recommendation doesn't suggest that we can use.
Can I ask a question?
Yes, sir, please.
Okay, you carry on. Let's do it. Carry on.
So coming to a TP again, so effects of pregnancy on breast cancer. So advanced disease, aggressive subtype, treatment approach. So what has been your personal experience?
If pregnancy on breast cancer, I usually have found the females coming in advanced stage, as already has been told. I really I have so limited patients, I would not be able to tell them the aggressive subtype as such, but I feel I normally get it at the third stage 3 and beyond. The treatment approach has been again very clearly mentioned. I don't think I need to add on that. How to approach in the first, second, and third trimester has already been told. So that is how I would approach it. I have had 3 patients of breast cancer with pregnancy, one of them metastatic, and she went on to have a child, and then unfortunately she died after 6 months of delivery. So that's the only thing I have on the metastatic part, and 2 patients on the early breast cancer.
I had also 3 patients, 2 were triple negative, 1 was hormone negative and HER2 positive. So Chetan, now effects of breast cancer on pregnancy. So So your experience in last 2 decades, premature birth, miscarriages, defects, and what is your take on breastfeeding?
As effect of breast cancer doesn't really affect pregnancy. Pregnancies are
Obviously, breast cancer means breast cancer and treatment. First.
yeah. The treatment for second and third trimester is pretty sorted out, that you have you preferably use doxorubicin-based therapy. If the usually these patients postpone surgery for some time, it is not the decision related to surgery is not much of an issue, and these patients who have completed their pregnancy successfully. So far, I've had only 3 ladies who had who conceived during their treatment, but their pregnancies were fairly uneventful.
So right. So Amish, so we'll come to the moderator again. So it's the age of AI, as Prime Minister Modi said. So issues with hormonal therapy in your premenopausal. So compliance. So how do you take SERDs plus minus OFS and AI plus OFS in a premenopausal ladies?
No. So you are asking compliance issue?
Yes, yes. So how many patients actually drop out? Like the soft and text had 20%. Even this trial had 15.4%. Not resuming. So do you see such incidents or lower than that?
Very lower. See, it all depends, Ghanashyam. There'll be different incidents in Tata Hospital, difference in AIMS, difference in Max, difference in my practice. Mine is a very limited, small number practice, and my compliance is good and much lower. And I'm sure it must be very high in AIMS and Tata Hospital.
No, Ghanashyam, one thing I want to clarify, and I think others can correct me. We are telling that in text and soft 20% did not adhere. The point is they did not adhere to the prescribed endocrine therapy. You have to read the lines. It is not that they did not continue endocrine therapy. So let's correct ourselves that in this trial, this is telling that around 20-25% did not continue on to the therapy at a 3.5 years time. But in soft and text, they did not go to the preferred endocrine therapy. It does not ever tell that they were out of endocrine therapy. So please correct. I think that is a very important statement.
Tarini, how do we ascertain compliance on oral tablet? It's purely from recall, na?
See what I'm telling you. I read the lines. Soft and text, 20% of the women discontinued protocol assigned endocrine therapy. So please let's not confuse ourselves. So we cannot assume, and what I read of the paper, that if you interrupt, you have higher chances that the lady will likelihood of not starting or restarting or having delayed the start of the endocrine therapy. If I'm wrong, someone may correct me.
So I think, it essentially depends upon who's the patient and, how much is the awareness level, how much is the motivation level.
No, Jyoti, I'm talking of just the restart, the not restarting percentage, which is not there. We have been telling that this paper at 15 to 20%, soft also at 20%. I want to differ on that.
I take your point that, that discontinuation may be just merely an interruption and not permanent discontinuation also.
No.
That could also
No, it is written here in the paper.
Might be changing of therapy, maybe tamoxifen, letrozole, both could be the interpretations.
No, it's very clear written.
But I also think that, when you're interrupting for a purpose, that, you are going to be starting it again. That is the premise of stopping.
Correct.
So when you have a premise for stopping, I think the chances of the patient going back on treatment is higher, that rather than during the course of normal treatment, you decide to interrupt and say, okay, I'm done with it.
So we'll go to the third ampere, Dr. Purvish,
to
resolve it.
Yeah, please go ahead. Go back to the moderator, please.
So just a very 30-second comment, if I'm able to. So I agree with Geeta that, these are highly motivated patients who wants to take the risk of being pregnant by interrupting and understanding everything. So in this highly select group, I feel that they go back to, resuming his chances would be really high. This is my
I have a point here. So if we look at the study, what they have written is that half of the patients, they resumed endocrine therapy at 26 months and 15% did not even resume at till 48 months. So that also, we can also read it this way, that by 26 months, only 50% had resumed endocrine therapy. So the actual interruption is probably much longer than the planned 2 years.
No, but this is possibility of breastfeeding and again getting little more time to resume. And also
Yes.
we are not sure that who conceived at what time point. So,
Yes,
so this all will be some soft factors. So because it is also written that breastfeeding is allowed.
Okay, let's go back to the paper. So we have 10 minutes only, no?
Patients
So
for 3.5 years. So you don't know at what point they have conceived and whether they're breastfeeding.
So this paper was an international paper, multi-center, single group. As I showed, this was presented in December, San Antonio also, though this got published in NEGM this year. And we'll come to this. So the normal endocrine therapy for early breast cancer is 5 to 10 years. So prolonged hormonal therapy, we understand there must be some high risk factors. And in pregnancy, the ovarian reserve. So we talked about this also with Dr. Geeta. So now, so we are talking about interruption. So to do or not to do, that is the whole question. So Jyoti, so now, so just get back to you in just short answer. So what is your experience now? We can say, so have you ever interrupted any patients before this trial when a patient has come to you and
while positive trial was recruiting, as an informed decision, I have interrupted for one patient, and I have discussed with a couple of patients because I was believing in that data. And also, one of my patients, which is also a case report, and I will show in this, during my expert comment, on her own, she conceived while on tamoxifen, and later she interrupted, although she delivered a normal baby. Then she didn't resume in spite of explaining everything, and she had again pregnancy, and that the second time it was, the child died, and again she conceived third time, so she didn't resume at all. So, but time and again patient expressed the desires, and they are from both general category and private category. So I have many patients who are desirous of.
So since we are discussing about pregnancy associated breast cancer, so it is customary to just understand the fact check. In a large population survey by Boyvan et al., including women from 20 to 44 years, the represented population in this trial. So unmarried or living in a consensual union, the prevalence rate of primary infertility, so no cancers here. So from 3.5 to 16% in the more developed nations, 6.9 to 9.3% in the less developed nation, and estimated overall median prevalence of 9%. So Dr. Madhuri, just a simple comment on this, because we have 10 minutes left only.
Yeah, so basically now the incidence of infertility is increasing. It's globally increasing, not only in developed countries, but also in underdeveloped countries. And I think in India today, the incidence of infertility is almost about 20%. And we have also seen that the sperm count is decreasing considerably. So whatever the sperm count was seen in men about 10 years back is almost 50% of that. So, when you have, there are several patients who get married at later in stage, and therefore many of them, when they come with cancer, they are infertile because they've not had children, so they have not been tested for fertility. And in my practice, I've seen there are several patients who are married even for 5 years and 6 years, have unconsummated marriage. So that's because of their social thing. So when we were talking here about sexual dysfunction, this is again one of the most important things when we talk about chemo and radiotherapy. But in normal patients who are not having cancer, they have a lot of sexual dysfunction today at this.
So Dr. Shirish, so have you ever thought of interrupting the adjuvant endocrine therapy in your patients before this paper is out?
No, not really. Now with this evidence, definitely I would think of it.
I'm asking, you are forced to, because patient. So there are patients.
Yes. So as Dr. Jyoti mentioned, I had one patient also who was on tamoxifen and she became pregnant. And she just came for a routine follow-up. We asked her, "Are you still taking the tablet?" So we had to stop the tablet, and she delivered a normal baby. And as again Dr. Jyoti mentioned, she didn't continue, and she took for about, and she had taken for 3 years, and then she became pregnant. So then she stopped on her own, and then everything was okay. So that was the thing.
So coming to TP, so just a few words on this. So why stage 3 was included, though Dr. Purvish touched upon, very few patients were there. So why 18 to 30 months? So any thoughts on that, different from Dr. Geeta?
No, what I feel is we should be discussing. I understand that the stage 3 for me is not. I will never interrupt in such a short time, because this paper only had less than 5 to 6% patient only on stage 3. 94% was stage 1 and 2. For me, the paper has a lot of concerns, and I would not tell it in very clear terms. It is practice changing. No, it is only thought provoking.
So come to that. We will come to that conclusion. No, so
no, I'm not concluding. The important is you have to look into the paper very clearly, and the paper has a very short follow-up, as was told of 3.5 months for a hormone positive is not just good enough for me. There is 94% 1 and 2, and I do not know the genomic risk factor. Are we dealing with patients who have not relapsed with ultra low risk? Mama print, the data is very clear with ultra low risk variety, where there are enough data that people probably can stop, and this is the variety they're looking at, to stop therapy at endocrine at 18 to 24 months. How many of these were ultra low risk? If that data is there, that gives us a lot of confidence to select among these patients. I'm also concerned about the 70% live birth. We have a gynecologist and the expert in fertility. What is the normal percentage of live births when we do assisted reproductive procedures or anything like this? So this paper very clearly tells you 70% live birth, 30% were non-live birth. That is a point that concerns me very much. And third and fourth last, people took it very lightly. For me, it is very important. 25% did not restart at the scheduled time and beyond. For a thing that was motivated patient was the word used by 2 panelists here. And if this is 25%, in my practice, it will be more than 50%. So these are my concerns. Whether it's practicing is a different question.
So Chetan, so why you can see the body mass index. So more than 25 or almost 30% patients. So why this was included? So any thoughts on that?
Maybe obesity as a risk factor for infertility may have been one of the reasons. I mean, this is just my thought. I really don't know.
Right. So now,
I think Dr. TP has a point that 3.5 years is just very short. They've mentioned those shortcomings, and that is one of the important limitations which they have also mentioned. But it's only 3.5. That's a little
right. So TP. So now you can see there is something called bootstrap matched cohorts. So
yeah,
so is the resort to such type of calculation or statistics?
See, we cannot, because it is statistical thing. What they basically looked at bootstrap is, if you look at the unmatched cohort, if you just look at the unmatched cohort of the patient who receive chemotherapy, and if you look at all the adjuvant endocrine therapies, there is a consensus that patient who receive chemotherapy can be termed as high risk. Even soft and text actually has termed that. And if you look at the unmatched and go to the paper, there is 12% difference in the patient who received chemotherapy in the other arm, not the interruption arm. But when they bootstrap it, they're actually putting it across these main criteria of the grade, the age, the nodes, and the T sites, and they're putting forward so that they can be matched properly. So this is what it is, but I don't think it is practically possible. It's a statistical thing to look at, that we are matching both the arms. And on the matching, is there a difference in the way we are able to find that interruption of the hormone therapy did lead to more breast cancer recurrences or otherwise? But one point I wanted to make out, which is not been highlighted here, with a limited evidence, even this paper states it, that patients who have interrupted for pregnancy, across 3 or 4 papers, references are there in this paper itself, that they have had lesser incidence of breast cancer recurrence. So what I am pointing out is, pregnancy, does it have a beneficial effect on breast cancer recurrence per se? So that is also, the data is there. And if you look at the discussion, this data is also there. So we also have to look into that factor.
Right. So Jyoti, So coming to the primary endpoint of this paper. So are you happy with these endpoints?
So, I'm happy, although I would say that the overall survival is a very important endpoint, but I also
You
feel
are
that
happy and sorrow at the same time.
disease-free, not lesser than that.
Like you are happy and
Yeah.
sorrow at the same time. Right. So ipsilateral, the locoregional invasive disease, distant recurrence, contralateral invasive breast cancers. So you can see external control versus, so we wanted 44 events and you can see the difference. And you can see the 3 years incidence of breast cancer. So nothing much different, 9.2% versus 8.9. So Chetan, though the follow-up is less, but still good to go.
I don't say that I'm going to start interrupting hormonal therapy from tomorrow. I would probably discuss, if a lady desires to be pregnant, I can at least say that, well, it is not unsafe to do so.
So what about this, Chetan, the distant recurrence at 3 years, 5.48 versus 4.5?
Well, that is something which the lady has been, I'll inform the lady about these things. And then it's her call.
Chetan, actually, it is beneficial. You are talking.
I know.
So that
I
is
know.
what I'm speaking. So it's
Actually,
actually
the other
beneficial.
meta-analysis which they have mentioned, that also has shown that the survival is actually better. The overall survival is better. I think there is a meta-analysis which is
Yes. There are actually 3 papers pointing towards the same thing.
Yes.
So coming to Dr. Geeta, so this is the pregnancy outcome. So so are you happy with this at this moment? So you expected this type of result?
I think this is quite good.
Right.
And I'm sure Dr. Madhuri would be able to tell us because, it is pretty high rate of pregnancy. I don't know whether in their usual art protocols, they manage to get so many pregnancies.
Yeah, so actually, basically, most international countries, because now we have, internationally and in India, basically, we are doing a lot of fertility preservation. And basically, all these patients who have cancer have either their oocytes, their embryos, or their ovarian tissue cryopreserved. And therefore, they really need not interrupt even the hormonal therapy because they can wait for 5 years and then go in for a pregnancy because they have with them either of thing, and they need not have a spontaneous pregnancy. So it really does not make a difference, that whether at what period, at what point of time you can go for a pregnancy. So even if a patient is 45 years, 47 years, we still give her a hormone replacement therapy, and we can transfer we can fertilize the oocytes if she's frozen the oocytes and then transfer the embryos, or transfer the embryos which have been frozen. Or if there's a ovarian tissue which is cryopreserved, you can transfer. So Denmark has the biggest registry of ovarian tissue cryopreservation, which is there for the last 15 years. And what they have seen is that they have several pregnancies after transferring the ovarian tissue. And now they have started using socially also to postpone menopause, the ovarian tissue cryopreservation.
One point which I wanted to clarify is that the assisted ART, which is done here 40%, is high because people opted for what madam is saying. They opted for the things before.
Per cycle pregnancy rate with ART is about 40%.
No. I'm not talking of that. The 40% ART in this paper is just because what you told, that in the Western country they have resorted to preservation of the ovum. That is why they ended up with this. Not that in actuality you need to do the ART can be as high. That's what I wanted to point out.
Two groups. If you are giving chemotherapy, it's best to cryopreserve either the everything. But if you are giving hormonal therapy, it's not necessary, because once you stop the hormonal therapy, and if the patient is young, she can resume her ovulation and she can have a spontaneous pregnancy herself. But if she is more than 37 to 38 years, then probably the chances of having a pregnancy is quite less. That is because we have to know that the Indian woman aged 6 years earlier than the Caucasian population. So this is one important thing which we need to remember. And if the patient is BRCA positive, we know that these patients are associated with decreased ovarian reserve.
Ma'am, Dr. Madhuri, ma'am, I have a question. This paper showed almost 25% miscarriage rate. So is that common in that kind of a population otherwise?
Yeah, miscarriage rate is common if the age is more than 37 years. Because and especially if they're conceived spontaneously, because the age of the oocyte is that much. And then the chances of having chromosomal abnormalities, that is aneuploidy, is much higher. And therefore, if you have an aneuploidy, the chances of miscarriage is higher because they've taken patients till 42 years of age.
Right.
So, after 37 years, the chances of miscarriage are always high.
And 8% of the offsprings were low birth, and surprisingly, see, not big. So 2% had a birth defects. So this has been showed here again.
That is normal. Normally, also the birth defect rate is that much, 2%. So it is not increased.
Right. So TP, now coming to the limitations. So besides the median follow-up, which we do understand. So any other concern? So as you said, it is not a practice changing, or even if you don't want to wait for 10 years and see, or so tell me.
So what I feel is now in this era when we do these things, I think we have to classify that patients who are high risk or low risk, ultra low risk. Although ultra low risk is not a standard of care now, but there is enough data that's emerging. And if one really wants to pursue this line of interrupting endocrine therapy for pregnancy at around 2 years of time, I think that would be a good way. And there is a present paper already with MammaPrint data we have already, that if it is more than 0.355 of the score of MammaPrint, you can really classify them as ultra low risk, and this could be the patient who have a 5-year survival, even at 2 years interruption around 97%. So that is what I was pointing out, that we need genomic help, and that should be really done. I would not be comfortable. Look at the forest plot, whatever is available, and look at the lymph nodes. If it is more than 4 and up to 9, there is a huge thing of a 20% relapse. And they felt, this paper, that beyond 2% was not justified to interrupt hormone therapy. So I would be very skeptical if it is T size, especially more than 3 centimeters, nodes 3 and more, and that is very important for me. And genomic risk categorization will be very, very important. And I think the live birth has not been answered. I'm really concerned of 30%, 70% only live birth. That is also concerned. What if papers assures me that yes, pregnancy can be done, can be tried, and in those select patients which you are comfortable with, who have a very low risk of recurrence, the interruption, the hormone can be interrupted at a particular point of time. Patients are more likely to get pregnant, and especially if they're 35 and below.
So Neha, so although the trial enrolled a substantial number of women with grade 3 disease, large tumor, node positivity, or a combination of these. So as the author said, possibly those findings are biased by the healthy mother effect. So what do you understand by this for the crowd?
Sir, this was not a randomized trial. This was a prospective trial, and healthy mother effect is subconsciously probably they have enrolled more women who were relatively healthy, apart from their breast cancer staging and risk. The other fitness parameters, if we look at them, probably more healthier women than what we see in the general population were enrolled for this, and that is what the healthy women, healthy mother effect is, and probably the outcomes might have been confounded by that.
Right. So Chetan, now coming to the last slide. So we have only 1 minute left. So this is our patient population, you can see, and somebody will understand that 10% BRCA positive will be there, even our population HR positive, HER negative. So many patients will be exposed to olaparib in coming days with the generic coming in. So many patients now, after the Natalie trial, after the Monarchy, patients will be exposed to CDK4/6, because today we're talking about interrupting hormonal therapy. So what will be the future looks like?
We will have patients who are pre-treated with targeted therapy like trastuzumab. I'm not sure about olaparib or CDK4/6 inhibitors, because right now we don't use CDK4/6 in the adjuvant setting in a great deal of patients. But olaparib, yes, over a period of time, we will have patients who will be pre-treated, and it would be interesting to see how these with these drugs, how the pregnancy outcomes are going to be there, because olaparib by itself has some issues.
Right.
By itself, it can cause problems. So
Dr. Sirish, your thoughts on this?
On the olaparib,
Olaparib, CDK4/6 in the adjuvant, it is coming in the adjuvant setting.
so as I mentioned in the chat box, these will be the patients who would be high risk, right, based on the monarchy data.
Right.
And I don't think we can extrapolate just because they are young and they have HR positive disease, they desire pregnancy.
Because
This is
there are stage 3 patients also this, na? In
No,
the,
stage 3, I would be absolutely no for this. I would not advise whether the patient insists, that is her call. It is a family's call. So I would not.
So TP, your comments?
Stage 3, no. Even stage 2 with high risk, as per the soft and text data, I'll be very skeptical. And sir has told how many of us do give this genomic as testing, how many of patients start. But if someone is wants to try this at such a short follow-up, I would be very comfortable having the assay, especially mama print. And if it is the ultra low risk, I'll be more comfortable probably stopping at 2 years and interrupting the pregnancy. That's it.
So thank you, TP, and all colleagues. So it's 8:26, and that's my last slide. It is only a short trip. Enjoy it. So I hand over back to Amish and Purvish sir for the experts of Jyoti's comment. Thank you so much.
It's only a short trip, so live in the moment also.
Thank you, Tarin. Thank you, Ghanashyam. It was a काफी detailed discussion. In fact, you covered 2 topics. One is this paper also and pregnancy-associated breast cancer also. I think दोनों का revision हो गया. That was very nice. Over to Dr. Jyoti. Dr. Jyoti, I think we would like to hear from you. I was on a semi-side pe chat with Tarini, and Tarini is hugely skeptical about a lot of aspects in this paper. And I echo each and every word what he has said, Jyoti. So one of the important point, I think you being an expert, you can give your conclusion that do you agree with so far whatever we have discussed, and is this really a practice changing paper based on whatever we have discussed for last 1 hour and 25 minutes. Dr. Jyoti is the senior medical oncologist, Tata Memorial Hospital, Mumbai, and she has done a lot of research especially I remember initially soft tissue sarcomas. All the panel discussions were made very interesting by Dr. Jyoti through her extensive knowledge, and now she's been doing a lot of research in breast cancer area also. So over to you, Dr. Jyoti.
Thank you, Amish. Can I show a few of my slides to just respond?
Yes, please.
Sure.
Right. So, I mean, it was a very interesting discussion. I agree. And, I would like to take you to this movie. Many of us must have seen it, List of a Lifetime. And actually, it really echoes with the scenario of a young woman with breast cancer. In this movie also, it happened that a young woman diagnosed with an aggressive breast cancer. And not, more often than not, I come across that kind of a bucket list when these young women, suddenly change from a very career conscious, very active woman, or even a homemaker who is the life of the family revolves around her, and suddenly become a breast cancer patient. And fertility is having a major concern. That is my, very strong feeling treating these patients for more than a decade. And fertility and pregnancy related issues are one of the top 3 priorities of young women with breast cancer and all the dedicated guidelines. It is also, shown by evidence that breast cancer patients have the lowest chances among cancer survivors to have a subsequent pregnancy. And mind that this analysis was adjusted for education level, previous pregnancy, and age because of several reasons. And the determinants of, fertility impairment is age, chemotherapy regimen, cumulative chemotherapy dosages, and more than 80% chances when we give such kind of chemotherapy that the patient may, develop some kind of impairments. Also, patient tends to inadvertently stop taking hormone therapy, compliance. Many of us in the panel also shown, I myself experienced this, that, if we are not taking an informed decision, they are doing this on their own because this is one of the very important biological desire of a woman. And many times now these patients are nulliparous or having only one child for several reasons. They want to become pregnant again. And interrupting compliance not in a defined manner, not in a not in a safe environment may further be catastrophic for ultimate outcomes. This is the case report I was mentioning, and the patient who on her own she interrupted and she never resumed, and she later on having a recurrence as well. So this paper, we have had every part of it discussed, so I'll not go into the detail, but in my opinion, this is really an important paper. But we have to be very cognizant about what are our own patients and how they are different. So I want to take you to this our Tata Memorial Registry for Young Breast Cancer. This is in a decent number of more than 1,200 patients, and all young, less than 40 years. And we have, so this is our data, and this is compared to the positive trial data. In positive trial data, there are more than 90% EBC patients, although they included even stage 3, but they were minuscule. So 90% stage 1 and 2, more than 4 lymph nodes, only 4.5%. And 425, I mean, majority of them only they were receiving tamoxifen. In India, our TMH data, they were aggressive biology, higher stages presentation. Stage 3 were 56%, higher T, 50% T3 and T4, and node positive 75%. 30% N2 and N3 disease, and 87% grade 3. Forget about TNBC and HER2 positive because that is not our concern, but we generally see our young patients with much more aggressive biology than what has been, the positive trial population. So we have to be very, very cognizant about this fact. Also, in our data, we have seen that stage is a most important determinant for survival, wherein the survival in stage 3 were drastically down in comparison to stage 1 and 2. So these were the patients wherein also the fertility counseling in some form, although not adequate, was provided to almost all of these patients. However, they were poor, detailing, and also when they were asked the leading question, they reported that when they were on hormone therapy, they had 45% of them who could report their symptoms. They have significant post-menopausal symptoms, including sleep disturbances, memory problems, mental exhaustion, mood swings, hot flashes, vaginal dryness, affecting sexual quality of life. And all these come out only when we ask the leading questions because of the study. 9% of this population only received LHRH agonist, although this is a little, prior data, 2015. Now they are much more, but, apart from LHRH agonist, acceptance of other methods are even more poor because they are not under insurance. They have to pay from their own pocket. The facility is not available in the center. They have to go out, and several other factors. Among the women who were desirous, these 105, not all attempted, but those who were attempted, also this is very subjective, but 7 women could actually conceive post chemotherapy, 5 had live births, and latency range was 2 to 7 years after treatment. The similar kind of picture in non-metastatic triple negative data, which is again, majority of them were young patients, 1,300 patients. Again, they were high risk population, 46% stage 3. Our gestational cancer registry, which we discussed, again, they were locally advanced breast cancer were 51%. So I want to bring this fact that, at presentation, our population is really different than what is positive groups population. And I'm very fascinated with this data. And also, there is a definite chance, at least with a limited follow-up, we could say that in this highly select group, there is a safety which was seen by this kind of trial. But we cannot compare apple with oranges. That is, I'm agreeing with few of my other panelists, that in high risk stage 3, multiple lymph nodes, more than 4 lymph nodes, I'm a bit skeptical because there the safety data is not as robust even at that short follow-up. So in early stages, less than 4 nodes, even as the nodes are less or no nodes, I'm more and more comfortable. And in those patients, it's a shared decision, of course, within motivated patients and their family and partners put together. We can do that safely, but in stage 3 or multiple lymph nodes, I'm skeptical at present. We must also be cognizant that this is a precision era, a precision cancer care era, and pregnancy, giving live births is essentially a biological need of a woman, and we need to respect it. So every person is different. What kind of risk they can take is also different, but it has to be a very well-informed decision if the person is having that kind of capacity, and I will understand that many of our patients are not again falling into that category. So the short-term data is promising. We need to definitely follow up for at least 10 years, which was the predetermined levels. And in my opinion, even longer, as this is a hormone receptor positive disease. But in a well-selected, aware, desirous group, I'm keen to start after a detailed discussion with patient and partner. That is my take. Thank you very much. And we need to customize the product to the customer.
Thank you, Jyoti.
Thank you.
Sorry, sir.
Thank you, Jyoti, and I just wanted to hand over to Amish so that he can do the final honor.
I wanted, in fact, Parikh sir and myself both wanted to thank and congratulate Jyoti. I think Dr. T. Raja was one, and you are the another one expert who have taken so much of pains to give your concluding remark and so much of education. I think this takes OBTO to the next level, as Parikh sir says. Thank you so much, Jyoti, for that. And thank you, Geeta. Thank you, Jyoti, and thank you, Ghanashyam, for such an interesting talk. Lot of questions and a lot of skepticisms about this. In fact, I also have a lot of questions about this, and I'm sure Parikh sir and I, we will discuss and bring probably the chapter 2 of this paper where we can address some of these questions. But I think one of the most important point is we have something to bank upon, whether we agree, not agree, whether we want to give this to our patient or not, but we have something to bank upon. I think that is one of the biggest power in today's age and world. With that, I conclude this session. And as always, the second Tuesday, 7 p.m. of every month, we really require your support like you people have been giving us, all of us. And we thank each and every one of you for being there for this particular webinar. Thank you so much from myself and Parikh sir. Thank you.
Thank you
And
very
the
much.
next session is on 8th of August.
Maybe we can have a picture, virtual picture at least.
Yeah, we should do that. We should do that. Can we request all of you to
Dr. Sirish,
switch on your videos?
At least TP has also on his camera for the picture.
I know, Tarini ne khatak se on kar diya.
Nathan, if you are there, please switch on your.
Sorry, sir, there is some problem with my camera. I don't know why.
Okay.
It's not coming.
Okay.
बड़े-बड़े लोग जब बोलते हैं ना, मानना पड़ता है बातें. और मुंबई वालों को तो स्पेशली.
इसलिए तो साहू, इसलिए we are agreeing to what you said. बड़े लोग को तो मानना पड़ता है ना. Thank you very much, Geeta. Thank you, Ghanashyam.
Thank you so much
Jyoti.
for having me on this. It's really
All of
good.
you have done such a fantastic job. This is so nice.
Hi, Geeta.
Hi, Sahu.
अभी हाई हो रहा है 1.5 घंटे पौने 2 घंटे बाद.
अभी तक बंदूक चला रहा था. Now he's happy. He's
Madhuri, I must give special thanks. She is our IVF specialist, and he has been doing so much work for cancer patients. I think she is highly underappreciated for all the work that she is. And I think it's a good opportunity to publicly acknowledge that. Thank you, Madhuri.
I would actually
Thank you so
all
much.
of you all to be the members of our Fertility Preservation Society, of which I'm the president currently for the next 2
Oh,
years.
nice.
I would be extremely keen. So I will connect with you.
Yeah, because we're doing
Okay.
a bit of work and we're also internationally publishing our data. And now we're wanting to create our own registry for fertility preservation, which we have not yet done. But we still find that patients coming for fertility preservation for cancer are quite less. They come, we counsel them, but then, I mean, it has to be a combined counseling in the presence of an oncologist and the oncosurgeon. Otherwise, the patient has different opinions from everybody.
Right. Thank you very much. Good night. Have a wonderful.
Good night, everyone.
Good night. Thank you, sir.
Thank you.
Thank you, Parikh sir, Amish,
Good
Bye-bye.
night. Thank you.
all the pains and everyone else. Thank you.
Thank you.
Close the webinar now.